Improving end-of-life care. Select Specialty Hospital of South Dakota is a critical illness recovery hospital. They have 24 beds and is an HIH facility, which means they are located in another hospital. They rent space and contract services, but they are their own entity. The types of patients Select cares for can have pulmonary issues, infectious diseases, wound care needs, renal, cardiac, and/or neurological disorders. Or they can have a combination of all of those and be listed as medically complex. Select utilizes an interdisciplinary approach to individualized care. They staff based on acuity, which typically results in about 5 patients per nurse. My learning goal is to explore, understand, and support the nurse, patient, family care, perception of care, and the experience of care during the end of life in a long-term acute care setting. The first learning objective I created for this assignment is to improve staff knowledge of end-of-life care and symptom management. This was accomplished by researching data of signs and symptoms of the dying patient and medical ways to manage them. I presented this material at a clinical meeting for the nurses. The staff were fairly knowledgeable of signs and symptoms of impending death, but voiced barriers to caring for the dying patient. Sometimes the nurses have a hard time with expressing or communicating with a patient that is in the dying process. Some felt they needed more education, not specifically signs and symptoms, but about coping, communication techniques, and dealing with varied dynamics within the families. Others felt they do not have the time to spend with the patient and family or find it difficult to find that time with the current demands of having the same workload. The second learning objective is to improve staff knowledge and awareness for cultural sensitivities and the spiritual needs of the patients with terminal illnesses. Many nurses are like myself, give me chest pain, hypoglycemia, or even cardiac arrest, something I can fix. But the fear of talking about death and the spiritual needs and wants of the patient, you'll likely see me hightail it the other way. So this learning objective was something that I needed to embrace. So during a few of the evening shift huddles, I presented a couple different scenarios to the staff and we role-played ideas to improve communication and breaking through barriers for difficult conversations. Practice is needed to feel comfortable in these types of situations, so this idea was suggested to continue throughout the shift huddles. Another idea that's in the works is creating a memory or comfort care cart for the patients and the families. The cart's going to include essential oils, cards with comforting sayings, stones with consoling words painted across them, spiritual books, poems, CD players with music, and grief services information. New cultural or spiritual symbols, ideas, and concepts can always be added to this cart as needed. My third learning objective is to enhance employee appreciation for a team approach during and after end-of-life care. You have to be able to trust your team in order to work together, provide quality care, and lean on each other during these difficult situations. During the clinical meeting, I asked them what support they felt they needed. The answers I received were a few minutes to myself while someone else is watching my patients. Some of them wanted to talk through the care or do a debriefing, and others wanted to do a group prayer. Through researching best practices for end-of-life care, I found that the Cleveland Clinic has a moment of silence in honor of the patient immediately after passing. They call it the pause. As they are gathered by the bed, they state this statement: "Let us take a moment to pause and honor this patient. He was someone who loved and was loved, was someone's family member and friend. And in our own way and in silence, let's take a moment to honor this patient. Let us also honor and recognize the care provided by our team." This was trialed with 2 patient deaths, and we feel like this provided a little bit of closure for the caregivers as they have spent a vast majority of time with these patients, as the patients at Select usually stay for 3 to 4 weeks. Afterwards, family is told they can spend as much time with the patient as needed, An additional step that we added is that the involved caregivers go to the conference room for a debriefing or a reflection and just support and lean on each other. Select has a healthy work environment. The staff morale seemed to fluctuate throughout the practicum, but the majority of the time it was pretty positive. The only thing I could recommend based on the literature is doing more employee engagement activities. Select promotes a non-punitive environment. They report errors and look for ways to change processes so the errors do not continue and patient safety is not affected. A common denominator in those errors were noted by agency nurses. A reduction in the use of agency nurses will likely result in fewer errors, but a hospital with a well-established safety culture could examine the education or orientation process of the agency nurses to improve patient care. Select needs to review the orientation process for all agency nurses because one shift simply does not seem to be adequate in some cases. As we know, quality care is a priority. A part of the quality role is looking at all deaths in the Quality Improvement Process Committee, which is held monthly. This team looks at workflows and ways to improve communication, care, and processes, as noted in the literature. The communication between the interdisciplinary team has been reflective to what we have been learning about throughout the semester. I've seen this with intradisciplinary rounds with the team, vent weaning rounds with the team, multidisciplinary rounds with the physicians, charge nurses, pharmacists, and sometimes case managers. This type of rounding gets everyone on the same page, focuses on barriers, outcomes, and quality care. The only area I see for improvement is the amount of time the physician spends rounding with the patients. A quick high five assessment and a rushed provider is the impression that I get. Case management and the charge nurses do a really good job communicating with the patients and their families as they guide them through the processes from what to expect and next steps, such as transferring a patient to the hospice center or staying at Select for the rest of their stay. Transition of care for patients I have been following have been pretty smooth. The team discusses, communicates with the physician, and is always talking to the patient and family about the next step and care to be provided. There is a limited amount of evidence-based practices in regards to end-of-life and palliative care, as there are minimal randomized control tests on patients that are dying. That being said, best evidence-based practices for communication, education, and quality are apparent. Hospitals need to have more educational programs to educate healthcare providers about quality end-of-life care, the signs and symptoms of death and dying, and symptom management. The materials presented in my first clinical meeting is going to be presented to the nurses as little mini series educations for all clinical future meetings. Communication has been linked to poor patient outcomes and errors, and poor communication with the patient and the family is often perceived as poor care provided. Role-playing difficult conversations will improve the nurse's confidence in these types of situations. Safe staffing ratios is always a hot topic in healthcare anywhere you go. It needs to be adjusted for end-of-life care patients in order for the nurses to have more time to spend with that patient and family during this time, as needs typically increase. A suggestion that I made to the clinical team is to have the charge nurse take over on care of the patient on Comfort Cares to be able to have more one-on-one time and attention. This past week on night shift, we had a patient that was nearing the end, and the night charge nurse took over care as the original nurse could not take care of 4 other patients and provide quality care to this Comfort Care patient. And this actually worked out really well for the team. The family actually commented on the individualized one-on-one care that they were receiving and were very happy. Hopefully this will continue. The only barrier with this is when the charge nurse is unable to drop her duties to comply. Quality care is essential to good patient outcomes, and although the patient is dying, a good death should be considered best practice. As my current role has been in leadership and administration, I have not been able to spend as much time at the bedside as I would have liked. This practicum has brought me back to the bedside, which has been where I've always thrived, spending time with patients. A personal side note, I think all administration should have to spend the day on the floor working or shadowing with a nurse or a nursing assistant every so often to never lose sight of the reason that we exist as nurses. I've been able to take a step back from my role at Select and observe the surroundings and care provided during end of life, and also what support is provided to the staff during death and dying processes. During my reflection, I see that we do not thank each other enough for the care that we provide. We don't stop and check on each other enough, likely because we're so busy with so many other tasks that have to be done. That goes to say, time with patients is also limited because of the million other things that we have to get done by the end of our shift. As I remember back to my grandfather's death in the ICU, I do not remember what the nurses looked like, the care they provided, but I will never forget how they comforted me after he passed. For patients nearing the end of life, it is often not just the care that you provide to the patient, but also to the family during this time. And I just want you to remember that although they may not remember what care you provided, the family will remember every second that took place during this care of end of life. During my shadowing, I have seen that these last moments are the last memories that a family will have with their loved ones. And if I can support or help the family embrace that moment, I will not only be touching our patients' lives, but so many more. Thank you.